start recording now that I'm done ranting. Okay, so for today, we're going to start looking at chapter 19, which is about prep and drape. And if you want to get your textbooks out, that starts, let me tell you the page. That starts on page 372. So if you want to have your book out. The first little bit goes over catheterization. So we're just going to skip over that. We don't need to go over that. We've already done that. So I didn't include that in this lecture, but we're just going to talk about prep today. And then the next time we talk about the chapter will be next Wednesday. We'll finish it up and we will close out with the draping part. Okay. So any questions or comments for me before we get started? Okay. All right, so here we are. Honestly, it already does feel like the surgical lamps are on tanning mode. I'm not gonna lie. The manufacturers say that the lights do not put off any excess heat, but that is a lie. I'm telling you right now. Okay, so the first little snippet in the book talks about patient preparation for surgery. So it's kind of become the standard of care that they will send the patient home from the office, like with their pre-op visit at the office or whatever, with some sort of soap and ask them to cleanse the area really well, like typically twice before they have surgery, the night before and the day of or something like that, which kind of helps to cleanse and prepare the skin. And Hibiclens is a typical one, so I put it here. It's a pink soap. I don't know if you guys have ever seen it, but it smells really good. It's really like the only prep soap that actually does smell good. And this also comes as a scrub as well. So we do have scrub brushes that have Hibiclens, or chlorhexidine is the generic name. The Hibiclens is the brand name. Okay, so they're going to ask patients to thoroughly cleanse the area where they're going to have surgery a couple times before they come. And then when they get to the pre-op holding area, of course, they're going to get the fancy gown. If it's a female, they might ask for a pregnancy test. They might do that right before surgery. Interestingly, when I was at the surgery center, I don't even remember what procedure we were doing. I think it was a knee scope or something, all elective procedures there anyways. And they did the patient's pregnancy test and surprise, the patient was pregnant, so canceled the surgery. So they had no idea that they were pregnant. So, you know, if the patient's pregnant and it's elective, they're going to cancel that. So in pre-op is where they're going to get them ready, put on their monitors, their blood pressure cuff, their pulse ox, you know, do all that fun preppity type stuff before we bring them back into the OR for surgery. Questions about that? So for mucous membranes, shout out to mucous membranes. There are really only two preps that we use that are recommended to be used on mucous membranes. So the two are the Providone iodine solution. And when we look at the two-stage prep, I will again point out that the prep comes with 2 bottles of stuff. And the one is a solution, or sometimes they call it a paint, and the other one is a scrub. All right, and the scrub is like a soapy scrubbing bubbles, and we never want to put scrubbing bubbles in the vagina. Okay, take note. You guys will be practicing preps. We'll do abdominal preps, we'll do vaginal preps, we'll do extremity preps. So you guys will get an idea of how that's done. It is within our scope. The circulator typically does it in the traditional role of things, but it's definitely something we can do. So as we kind of get deeper into the program, we will practice prepping. Okay, and then the other one is this PCMX. PCMX is also okay to use on mucous membranes. This is a very long word right here. See it? Parachloromethaxanol. That's why we call it PCMX. It's like a clear soap. So as far as hair removals, we used to do this. When I started working in the OR, we were using sterile razors. So the hospital will buy these in bulk and they'll sterilize them. And then we stock them in the rooms. And there's a whole bunch of no-nos that we do typically in the operating room. Patient's not supposed to be shaved in the operating room. We do it all the time. So if it is occurring in the operating room, then, bring them in, and once they're asleep or whatever, we're going to do a shave. Whether we shave or not, who determines that? Is that the nurse? Is that the surge tech? Who determines if we do a shave?
Wouldn't the surgeon have it on the orders if that's what they preferred?
Yeah, typically the surgeon is the one that's going to say, and sometimes it will say on the preference card, which is like our orders that we use, like the surgeon's orders. Sometimes you just have to ask, so if, the preference card may say if there's hair, shave it, or the circulating nurse may just double check with the surgeon and say, hey, do you want to shave? Okay, yes, you're absolutely right. So the surgeon's going to determine that, their preference. And then, like I said, we used to use this razor, but we don't do that anymore. We have switched to these little clippers. And this is one type of clipper that you might see in the operating room. Pretty much every operating room is going to have like a little docking station, a little charging doohickey that the clipper will sit. It'll sit in there, it'll live in there. And then when it's time for the shave, which the circulator typically does, they will get the shaver, and then there are single-use blades, okay, clipper blades. So they will, get a new clipper blade and they'll snap that on there and they'll do the little shave. They usually get a roll of tape. And as that, which sounds weird, I'm sure, but as they shave, they will use that tape to just like get the loose hairs up. And so they'll go ahead and do it that way. Who knows why we switched? Why don't we still do the razor?
Is it because it can potentially cut easier?
Yeah, right. It's definitely because of that. And those little cuts, yeah, Tori, you're right too, that causes little abrasions, and that's a breach in the skin, right? So that creates an opportunity for that opportunistic bacteria like Staph aureus or Staph epidermidis to get in there and cause an infection, right? So the clipping should, if you do it right, should avoid that, right? Questions about chafing or hair removal? A couple things that the book mentions that kind of grabbed my attention was that the eyebrows are never shaved. We don't want to shave off anyone's eyebrows, even if we're cutting into them or across them. And the other thing is we don't ever want to cut the eyelashes. And when we're doing like something around the eye, and a good example is like upper blepharoplasties, they will put stitches, and the stitches are going to be really close to the eyelashes. And your surgeon can get a little bit twitchy if you're cutting the stitch and you're too close to the eyelashes. So just be aware that you may get the warning of don't cut the eyelashes. And you can say, yeah, I already know that. No, don't say that. That sounds snarky. I was just kidding. Okay. Questions about this? Anything else? Okay, skin marking. So when the patient is in pre-op, their surgical site is going to be marked, especially if it's side specific, like an arm or a leg or a hand or a foot or a shoulder or an eyeball or something like that. Typically, if the patient's having their gallbladder out, they're not going to write like on the right side gallbladder, or yes on the right side. But if it's side specific, we're going to ask them to mark it. The surgeon's going to double check. And we want to make sure that we're using some sort of skin marker or some sort of marking device that is approved and recommended for marking the skin, not just a Sharpie or a ballpoint pen or, a crayon. Okay. So something that is specifically for that. And here's an example of one. This is what it looks like in the package. This is, there's several manufacturers of skin markers, but this is pretty much what they look like. Some of them are double-ended, where they have like a thicker tip on one end and a finer tip on the other end. But this is what they'll use. Sometimes, like I said, surgeons will go into the pre-op if it's a plastics case, like a breast lift or, something like that, and they will mark on the patient prior to. They're like going to do measurements and all kinds of fun stuff, and they're going to mark up the patient before surgery. If you are the one prepping, whoever that is, needs to be very careful that they don't scrub off the marks. It seems like the skin marker wants to stay on everything else except for the skin. Interestingly, I think it's because the oils that are on our skin. So we also have these come in our packs, our sterile packs. And so we'll have this on the field. You can see that it has a little measuring device. And a lot of times it also has labels, like blank labels that come with it, so that we can use this to label our medications or whatever the case may be, or, play tic-tac-toe, whatever. Okay, so I think I've done way too much talking because my voice seems to not be that great today, so I apologize. Yeah, so we're gonna mark the site before. Questions about that? Pretty straightforward. Okay, let's watch this little video now, shall we? See if I can get it going. Go.
The surgical skin prep is performed immediately before the start of surgery, after the patient is anesthetized and positioned. The surgical site and a wide area around the site are cleansed and painted with antiseptic solution. Skin cannot be sterilized, but the number of bacteria can be reduced significantly with antiseptic cleansing or a coating of antiseptic on the skin. Only antiseptic agents approved for use on skin may be used for the prep. 5 antiseptics are commonly used for the surgical skin prep: iodophors, chlorhexidine gluconate, triclosan, parachloromethaxanol, alcohol. Before the surgical skin prep is begun, all supplies are gathered and placed on a small prep table near the patient. The skin prep is completed using aseptic technique. Sterile gloves are worn and supplies are sterile. Manufactured sterile prep trays are available and contain all or most of the supplies needed to perform the skin prep. The skin prep follows a prescribed protocol. Before prep is begun, the prep kit is positioned on a small table and outer wrapper opened using sterile technique. The sterile outside wrapper is folded down over the table and a sterile field is created. The sterile prep gloves are applied with open glove technique. Prep solutions are poured into a basin and all other supplies are placed on the table. When more than one procedure is planned during the same surgery, the circulator must prepare each site separately using a different prep setup for each site. Surgical sponges are reserved for surgery and not to be used for surgical prep. Each one must be accounted for. Surgical sponges have a radiopaque or X-ray detectable strip. Prep sponges are white and do not contain a radiopaque strip. Used prep sponges are discarded according to facility policy to keep them out and away from the sterile field. Before prep has begun, the operative site and surgical procedure should be validated by the surgical team. There are two methods of prepping. One method is to use antiseptic soap solution, followed by a coating of antiseptic. The other is with antiseptic solution alone. The type of prep used is based on the surgeon's preference. During procedures performed under regional anesthesia, it is important to respect patient modesty and provide a brief explanation of the procedure before starting the prep. The skin prep starts with assessing the prep site before the prep begins. Any lesion or disruption in the skin must be documented in the patient chart. If the prep area is grossly contaminated with dirt, debris, industrial chemicals, or other foreign material, the site is cleansed as a separate procedure prior to the surgical skin prep. Organize the prep supplies on a small table near the patient. Don sterile gloves using open gloving technique. Place 2 or more sterile towels on either side of the patient to catch any prep solution that might pool. When placing the towels, make a wide cuff in the towel to protect your gloved hands from contamination. A small amount of antiseptic solution is poured into the prep tray. Dip a prep sponge in the antiseptic solution and squeeze out any excess. Use one sponge at a time to perform the prep. The prep is performed in a circular pattern, starting at incision site and moving outward. As the area of the prep is extended outward, do not bring the sponge back to an area already prepped. As each sponge reaches the periphery of the prep boundary, discard it. Any area that is highly colonized with microorganisms, a contaminated area, such as a colostomy, skin ulcers, or a foreign body, is prepped with fresh sponges after the surrounding area is prepped. Following the scrub prep, a sterile towel is used to blot the skin. In two-stage prep, antiseptic solution is applied to the surgical site after the scrub prep. Fresh sponges are dipped into the prep solution and excess squeezed out. Beginning with the incision site, prep solution is applied in a circular motion from center to periphery. The same principles used during the scrub prep apply to this stage of prep. The prep solution is allowed to air dry.
Ta-da! Okay. All right, so, excuse me. Let's have my individuals whose last names end with the letter start with the letter M through V or Z, I guess, but V is the last one we have. Put into the chat what you learned. So last names M through V from the video. Let's have the rest of the class watch, and then we'll have you add additional things. Okay, so M through V, put into the chat what you learned from the video. Oh, it can be toxic. That's scary. Blot the excess prep with a towel. Yes. Yep. If multiple surgical sites, new prep is used. When to throw out a sponge. Yep. Oh, good job, Tammy. Yes, that was one of my questions I wrote down. The first thing we do is check skin integrity. Very good. Prep is chosen by surgeon. Yeah, they think that they can call all the shots, don't they? Yep, blot the excess. Start at the incision site. Yes, ma'am. Yep. Sterile towel after the prep. Kind of dry it up a little bit if you're doing that antiseptic prep. Good. Anything else? What else? Circular motion moving outward to the periphery. Yep, we got a drape, right? Ian is saying, we put some towels down to catch the excess. Good. What about my B through L? Anything else you guys noticed that isn't on there yet? What else would you guys add? Colostomy, yep. A highly colonized area is going to be prepped last with a different sponge. Yep, good job, Tori. What else? Yep, you want to squeeze out the excess prep before you apply so it's not like dripping everywhere. Very good. Anything else you guys can think of? Takeaways? Do you have any questions? Of course, this is just one type of prep, right? There are various types. We'll look at those. Yep, Jonathan, you're absolutely right. Oh yeah, Tammy, good job. We used open gloving for that, right? So, you know, the process would be a lot similar to when you're doing the catheterization. You know, you would gather all your supplies, do your hand wash, open your prep, then do your, you know, make sure your patient is exposed, open your prep, and then do your open gloving, and then go ahead and do your prep. Good job. A good example of a time where we might need two different preps is with like an abdominal hysterectomy. If they're doing an abdominal hysterectomy, a couple things are going to happen. They're going to have two preps, but what the nurse will typically do is open the first prep and the catheter kit, and frog leg the patient, do the perineal prep, the vaginal prep, and then that serves also as the prep for the catheter insertion. So they'll prep and insert the catheter, and then legs go together, and then they'll prep the abdomen separately. Okay, so if you're ever like pulling the supplies for abdominal hysterectomy, maybe the card will say it needs 2 preps, maybe it won't, but intuitively you should know that for abdominal hysterectomy, they're going to need those 2 separate preps. Another example would be like a skin graft. If we're taking a split thickness skin graft from the thigh, let's say, and we're putting it on the arm, then we're going to have 2 separate sites. The donor site and the recipient site are both going to be prepped and draped out, which is always fun to drape out two different areas. Surgeons have a variety of fun ways to do that. It usually means you have one type of every drape under the sun because you're not sure how your surgeon's going to drape it out. And then, you either ask when they get in there or when you see them in the lounge, hey, I'm in your case. How do you want to drape this? Or, you open the minimal stuff, and when the surgeon comes in, you ask, and then the circulator opens the stuff that you need. So those are a couple examples I can think of. Any other questions or comments about the video? Okay. Oopsie. No. Okay. Wait, is that the right one? Yeah, okay. So let's talk about some different types of prep solutions. All right, so the first one, or agents, I guess the book calls them agents, special agents. Okay, so alcohol is first one on our list. 70% alcohol is going to kill about 95% of microorganisms, whether it's gram positive, gram negative bacteria. However, alcohol does not kill spores. So typically we use it in combination with something else like iodophor, all right, or iodine, so that we get that spore killing ability. So it's rarely used just by itself. Something that is really scary with alcohol-based preps is that it is highly flammable. We also do not want to use like ChloraPrep and DuraPrep are the 2 most common alcohol-based ones. They're a single stage prep that you're going to see out there. It's basically you just crack the back. You can see that you just push this little guy in right here, and it's going to allow the fluid to saturate the sponge, and then you just go about your business. Typically, in the package, there will be 2 little swabs. And so if they're doing the abdomen, they can swab the belly button first, right? You want to like poke the swab on, saturate it, just like poke it on the sponge. And so you can get some prep solution on there a couple times in the belly button, and then, do your prep. But if it's an extremity or something like that, then of course we wouldn't need those. What else was I going to say? Oh, we don't want to use like DuraPrep or ChloraPrep or any alcohol-based thing to prep near the eye or ear, because it could cause damage internally to those structures. And also mucous membranes. We don't want to use these on even like, genitalia, like the penis and the scrotum. We don't want to use these prep agents on that. Another consideration is that this stuff does not come off with just a wet rag like the other preps do. It sticks and adheres to the skin, so there is a special lotion that has to be used to remove this type of prep. Questions about alcohol prep? A couple other things that come to mind with alcohol prep. One, if they use it to prep the abdomen, there is a good chance that there is going to be a pool of prep solution in the belly button. Okay, it has a tendency to collect there. Ian, good question. Yeah, they have little baby ones that they can use for like IV insertion. Yep. Yep, or like percutaneous catheter insertions too, I think. Yep, you're welcome. I think we have some baby ones in the lab I can show you, and then we have the full size ones too that we use in surgery. Yep. Let's see, what else was saying? Oh yeah, a little pool of this stuff. So when you drape the patient and you drape the abdomen and you get ready to do surgery, you just want to take like a sponge and just dry up that pool of fluid in the belly button. And then you want to discard that sponge because the belly button is considered contaminated. So we don't want to reuse that sponge on something else. So dry up the prep solution in the belly button with it and then just discard it into your kick bucket. Also, with this type of prep, DuraPrep, ChloraPrep, there is a 3-minute dry time. I think it was Banner Hospital, one of the Banner hospitals not that long ago, a few years back, had a serious fire. Not that all fires aren't serious, but extensive fire due to one of these alcohol-based solutions. So now they all have these little kitchen timers that are glued to the wall, and they will set it for 3 minutes. After the nurse preps, she'll set the timer, and everybody just stands there and waits for 3 minutes, right? Because as soon as that surgeon makes the incision, what do they want to stop the bleeding? What do you pass after the knife? Who knows?
The Bovie.
Yeah, the Bovie. Bovie and alcohol. That's a fun time right there. All right, so that could cause an explosion. That could cause a fire at the surgical site. So that dry time is really important.
Yeah, just a little bit of a ignition, if you know what I mean.
Yeah, just a little bit. Just a little bit. I was just reading your comment, Ian. Yeah, in pre-op, I don't know if it's a standard of care now that they're using the little ChloraPreps or DuraPreps. I think it's only contraindicated if there's some sort of allergy to iodine or a patient's had it before and had some sort of adverse reaction to it. But yeah, even alcohol has like a 10-second dry time, or a 10-second contact time rather. So ChloraPrep is a better choice, I think. Yep. Yeah, so fire is definitely a thing. We'll talk about some other risks as we go along here. So CHG, again, the chlorhexidine gluconate, it is another type of prep agent that can be used. The book talks about residual activity. Who knows what that means? Residual activity.
It's the gift that keeps on giving.
Yes, indeed. Yes, so it continues to kill those microbes even after it's been put on the skin. It continues to work a little bit in our favor. Thank you, Tammy. So Hibiclens does have some residual activity. We don't want to use it around the ears, and we don't want to use it on little ones that are 2 months old or younger. But typically, what I've seen is like big jugs of it that are just like kept in the operating room somewhere, maybe on the bottom of a prep stand or whatever. The nurse will open some sort of prep kit. This is just one example. There's other ones that they'll pour some of the Hibiclens into there, and then what I have experienced is they'll just ask you to squirt some saline in there from your asepto, because you usually have saline on your field, and they'll just use that to mix with it, or they can go get a bottle of sterile water and pour some sterile water in with it, but they don't use it straight. They usually add a little bit of water to it, and then they use that to scrub the skin. All right, the Hibiclens isn't recommended on open wounds like burns or for infants as well. Iodophor, I would say this is the most common prep agent that is used unless there's an iodine allergy. But iodine is really irritating to the skin. So they mix it with Providone, which is like, what do they had a special name for it? It's, I read it in here, a dispersing agent, a synthetic dispersing agent. So it's Providone iodine, and when you mix those two together, they call that iodophor. All right, and this is what the prep kit looks like, and we have these in the lab. We'll be using these to simulate prep, and has a whole bunch of goodies in there. Not all the time the tweezers do I see, but it's going to have a generic pair of gloves. It's going to have a couple Q-tips to swab the belly button. It's going to have some dry towels and some drape towels, blotting towels, and some drape towels. And then it'll have these sponges. It looks like they're kind of split, so you can kind of pick up the edges and hold them and protect your fingers from the skin. And, you know, part of it will stay flat and the other part you'll hold on to. You do the little scrubbing. And then these little sponge on a sticks are in there as well. So there's one bottle, and I don't know which one's which here at this point because I can't read it. But one will say scrub and one will say solution or paint. So the scrub is what is going to go, the scrubbing bubbles. You'll take out these popsicle sticks and you'll take out these sponges. And where these sponges are, you'll pour the scrub, and where these sponges are, you'll pour the solution or the paint. And these are the scrubbing bubbles, so that's what's gonna go first. So like you saw in the video, you'll drape. So if it's abdominal prep, you'll tuck your drapes under each side of the patient. And then you'll pick up 2 sponges and put them in the scrubby bubbles and kind of squish them out. And then in a circular scrubbing motion, starting at the umbilicus, after you've cleaned the umbilicus, of course, working in that outward motion, but scrubbing in little circles like this. Part of the reason that we do that is because of something called mechanical action. And mechanical action also helps to kill microbes, disrupt them, disturb them, remove them from the skin. We do the same thing when we scrub our own skin. We're going to scrub in circular motions, helps to scrub those microorganisms off. And so we're going to do that 3 times over, working to the periphery, trash the sponge, do it times 2, trash the sponges, times 3, trash, and then blot, right? This is the 2-stage prep. And then we're going to use the popsicle sticks and in the paint and just paint it on, starting at the umbilicus out to the periphery, trash. Do that 3 times. Voila. You don't usually blot the paint or the solution. You just leave it on the skin, but some surgeons could prefer that you blot it, but that's not what I've typically seen as practice. Iodophor has some residual activity, but it can be absorbed through the skin. So at the end, after surgery, we are going to want to wash that off the skin. Well, this is something that is very nice for your circulating nurse if you help with it. All right, so once the dressings are on, we cover them with a blue towel, just a folded towel, typically to just keep them clean and hold them in place as we're taking the drapes off. And then the nurse is going to come and relieve you of your duty so that they can tape the dressings on. And then you want to go get just like a clean lap or a clean towel or something like that. Dip it in your saline and come back and help wash that iodophor off. All right. so that it doesn't stay on the skin, because it's still going to irritate the skin even though it's mixed with that Providone. Okay. Burns can result. So those drapes that we use that Ian said absorb the excess, if that solution is allowed to pool underneath the patient, that can cause a chemical burn on the patient. Okay. And then we don't want to use that on infants. We don't want to use anything on infants. We can't clean them with anything. Okay. Questions about iodophor? There are a couple other different types I've seen. There's an iodophor gel prep, and it's like this thick, gooey gel stuff that they just spread on the patient and just leave it there. I don't even know if they use gel preps anymore, but it was a thing at one point, betadine gel prep. And then those ChloraPrep is an alcohol iodophor or iodine combo. Okay. This is safe to use on mucous membranes, remember. So if prepping the vagina or prepping the perianal area, this is typically what we'll use. Usually don't prep inside the mouth or anything like that. So those are typically the mucous membranes that do get prepped. Triclosan. Interestingly, there have been trace amounts of triclosan found in beauty products, toothpaste, you know, and they have been linked to a series of complications like hormonal problems, allergies, cancer, central nervous system damage. So in the 1970s, they started realizing that because it was a very common soap that we used to clean with, and then we decided, yes, it's good to use in the OR as a skin prep. And then in the 1970s, they were like, wait a second, we think that there could be a correlation between the use of triclosan as a prep and central nervous system damage. So they retired it. However, it is still found in operating rooms. Sometimes. When I worked at the surgery center in Tucson, there was one surgeon that refused to use anything but triclosan. So there you go. I don't know what else to say about that. And then the last one that we kind of already gave mention to was that PCMX, which is also safe to use on mucous membranes. It is ineffective in the presence of organic debris. So if the skin is soiled, or if there's, you know, whatever on the skin, oils or something like that, then it's not the best choice, but it is safe for mucous membranes. Questions, comments? Okay. So here's a look at what, just a closer look at that prep kit that we saw earlier. Some of them are called dry prep kits, and they come with just this stuff and not the prep stuff. So then you can add whatever you want to it, but this would be that 2-stage iodophor prep. Sometimes it's called a betadine prep. You might hear it called that. So if they're like, we're going to use a betadine prep for this, then this is probably what they're talking about. I've also heard it called a scrub and paint. I've also heard it called a B&B, betadine and betadine prep. So old school nurses or docs might call it a B&B. They might call it a scrub and paint, just so that you know what they're talking about. Okay. But that's what comes in there. I remember being in school, and you know, in my school, it was common for the older students to teach the younger students. And I remember one of the gentlemen was getting close to graduation, and we were looking at these prep kits, and he said, "See these right here?" He's like holding it up. "You see this?" And I'm like, "Yeah." And he's like, "They stick this in the vagina." I was like, "Oh, sounds horrifying." was like at the beginning of my program, I was like, wow. But it's true, they do. They can use those. They work well. They can also use like a sponge stick with a sponge loaded on it. So instead of having these manufactured kits that they purchase, hospitals may choose to make up their own prep kits, and they're going to have sponges and a basin and some sponge sticks and some towels. You may see those on the shelf, and they may not use these at all, just as a cost savings kind of thing. Okay. So we talked about the difference, and the video showed the difference as well between the two stage, where you do the scrubbing bubbles and then you dry and you do some sort of paint. That would be a 2 stage, or the single stage, which is, you know, just fix it in and forget it. Okay, 1 step. Some risks associated with skin preps. Book talks about a few. It gives a shout out to allergy. So of course, we've already been talking about how if individuals are allergic to shellfish or iodine, that we shouldn't use the iodophor prep. You know, there could be other allergies associated with it as well. Those prep kits do have latex gloves that come in them, so that might have to be switched out. That would be a good time to use one of those prep kits that are put up by the hospital, because they don't have latex gloves that come in them, and then you could just pull your gloves separately. Chemical burns is another one. So chemical burns, if the solution is pooling underneath the patient, can lead to a chemical burn or a thermal burn. The book talks about, warns about pre-warming prep solution, which I've never seen in my life, but maybe there are some people out there that are like, warming prep solutions, but we shouldn't do that. Okay, so just tuck that away somewhere. We talked about their potential flammability and their potential toxicity as well. Questions about risks associated with the different prep agents? Okay, we're gonna take a break, and then we're gonna do an activity. It is about 7 after, so how about 10 after 9, 9:10. So we'll take a break until then, and then we'll come back and we'll discuss our activity, okay? I'll see you in a few. Thankfully. Okay, here we go. All right, so let's go to our Google Slides. And let me get my screen situated here 1 second and get my chat up here. So if you guys need to ask questions, I can see it. Presentation mode. Okay. Overview of the prep sites. Come back. Okay. Okay, so we already know what's going to be reviewed. So let's start with group 1, who had the face, eye, and ears.
So for the supplies, for the face, the supplies needed is normal saline, cotton swabs, cotton-tipped applicators, towels, non-sterile comb, and water soluble. Soluble. Yeah, I think I wrote that wrong. Hair gel, and then ear-occlusive towel drape, cotton balls, cotton-tipped applicators, prep solution, according to the surgeon's order, of course, and then prep towels, and then for the eye adhesive barrier drape, lint-free cotton balls, small basin with warm saline solution, towels, bulb syringe, and eye sponges.
Good. Sometimes if it's like for a facelift, if it's going up in the hairline, like this is a great picture that you have right here. But if they're prepping into the hair, because for facelift, the incision is going to extend into the scalp behind the ear, and then up here as well. So the circulating nurse might have like little bitty rubber bands, and they'll like pull the hair back or like section the hair. Sometimes the surgeon will do it in pre-op, those kinds of things too. So that might be something else that you see. Okay.
So for our descriptions, the face prep includes the neck or chin upward to the hairline, and the ears may be included as ordered. The eye includes the eyelid, brow, face to chin line, starting at the eyelid and working outwards. And then the ear includes the external ear canal, folds of the pinna, edge of the hairline, face, and jaw.
Yeah, and a lot of times if they're not working inside the ear, then the circulating nurse or whoever's prepping is just going to open a couple cotton balls onto their prep, their sterile, after they open their prep and create their sterile area, they'll open some sterile cotton balls onto that area. Sometimes they'll ask us for a hemostat, because a hemostat makes a nice little device to like push the cotton, clip the cotton ball and push it into the ear. So sometimes they might ask for a hemostat from us to do that. Good job.
The prep solution for the face is non-alcohol diluted povidone iodine. I'm not sure how to say that word.
Providone, yep.
And then we don't use CHG as it can cause hearing loss or alcohol.
Very good. Excellent. I don't think I have anything to add to that.
And last, for our techniques, for the eye, you start the prep at the eyelid, prepping in a circular motion around the eye to within an inch of the hairline. Repeat that 3 times using new sponges each time. And then you rinse the prepped area with saline and flush the conjunctiva. For the ear, you want to place the cotton ball inside the external ear canal, cleanse the folds of the ear, extend to the hairline, face, and jaw, and then remove the cotton ball. And for the face, you want to secure the hair away from the face, and then prep from the incision area outward, repeating with fresh sponges, and then rinse with cotton balls dipped in warm saline.
Yep, very good. Good job. Thank you so much for that. All right, group 2, neck.
Well, the neck. Neck prep area extends from chin to the nipple line, or waist and around the side of the body.
For supplies, you need sterile towels, an occlusive towel drape. Prep solution depends on the surgeon's order, like cotton balls.
And technique is use sterile towels and then peripheral of prep site, exclusive towel drape used to exclude face and airway, starting at prep site, and apply in a circular motion, and showing a little picture to the top right where to start and work your way out.
Awesome.
And with another slide as well.
The contradictions, it depends on like allergies, age, like doctor preference. And then we said like non-alcohol solutions. And then indications, we said requiring patients to bathe or shower with an antiseptic agent the night before. And then like hair surgery maybe, or hair surgery, hair removal may be necessary, but it depends on like the surgeon and his preference.
Perfect. Maybe we could save the hair and implant it like somewhere else on the body, like on this guy's head. You were looking at his head thinking he needed hair surgery, pretty sure. Yeah, absolutely. A lot of times when they do their draping, like they're gonna tuck their towels like right in this little area right here for their prep. And sometimes like if let's say we're doing a right carotid endarterectomy, that means the neck's gonna need to be prepped. And sometimes they'll extend it up to the ear. But then the head's going to be turned to expose that site. So it might vary depending on what area of the neck. If they're doing a thyroid, then, they're going to put a little pillow under the neck and it's going to like extend the neck a little bit to open up that area. So it could be modified depending on what they're doing there. Yep, good job. Anybody have any questions so far? Comments? Okay, kids. On to the breastises. Who's going to talk about breastises?
I thought I was unmuted.
Oh.
I was like
No,
reading here. I was like, no reactions. This is great. The prep region depends on type and the extent of the surgery and the patient's position. So in other words, if it's the chest, depending on where it starts. I mean, that's pretty much, I guess, all I got to say with that, the incision site. But it can extend from the chin to the umbilicus and includes the lateral thorax on, lateral thorax on both sides. If the umbilical is included, clean it first, then prep the area starting from the incision site. If the shoulder is included, an assistant should abduct the arm so that the solution can be applied circumferentially.
Yep, you're absolutely right. Yeah, for mastectomy, generally they will include the arm in the prep as well. Good job.
And then there's our picture.
Yep, good picture. If they're doing like, sometimes the patient will have had a mastectomy just on one side, and then they'll put in an expander. Can you mute if you're not talking because it sounds echoey? So if they're just doing a breast augmentation on one side, like I said, they've had a mastectomy, they had expander put in, and now they're coming in to surgery to get the expander taken out and an implant put in, the surgeon will still want to prep both breasts. So that way they can have a reference so that they can get the augmented breast to look as close as possible to the natural breast. Or sometimes they'll put a little tiny implant in the other breast as well. So, but typically if they're working on one breast, they do want the other one prepped and draped as well. Okay, good job. Good job getting that word pronounced circumferentially. Everybody knows what that means, right? That means all the way around. Okay, moving on.
Supplies needed are sterile gloves, sponge forceps, small basins, sterile water, sterile towel, cotton-tipped applicators if the umbilicus is going to be cleaned, antiseptic scrub soap if required, prep solution and prep sponges. Indications: check the skin for abrasions and burns if you go back with which solution is used. Give me 1 second. Sorry. For tissue that is suspected of being cancerous, it must be prepared gently to prevent tumor cells from seeding the surrounding tissue.
Very good. Very good to include the seeding. So gentle prep. Also, if it's a breast augmentation or something like that, again, the surgeon's probably marked up the patient. So a gentle prep is going to be required so that you don't wash off any markings there.
So does that work the same? Like, I mean, some of it, it's like you have to put pressure and you have to scrub it. But if they've marked it up and we do a gentle scrub, is that sort of, I don't know, halfway? I mean, is it still considered a full scrub?
Yeah, it is kind of halfway because you're not getting that. I mean, you're getting the skin is getting the contact of the soap or the antiseptic, but that mechanical action doesn't play as much of a role. Sometimes it seems like, maybe I should say this off the record, but sometimes it seems like plastic surgeons, they just go meh to, sterile technique, or the plastic surgeons that I've worked with are the surgeons that have the worst sterile technique of any surgeons I've ever seen, honestly. I've worked with surgeons that don't even drape when they do liposuction, worked with surgeons that come into the OR with no hat and no mask, and you're open and ready for surgery, and, they're just bring their purse and their coffee in there. To get down on their knees, it's just weird. And I don't know if they have the impression that it's just kind of superficial type of surgery. I mean, I don't know. That doesn't even make sense to me, but I can't really figure out why their sterile technique is so varied, let's say. Oh, Jackie. What else was I gonna say? Oh, something else that is weird for us is that when they're doing breast surgery, because they're gonna want to drape like really wide so that you incorporate the full breast. And so when we drape, when we start to drape for breast surgery, we will take 4 towels and the surgeon will square off around the area. A lot of times surgeons are going to take a skin stapler and they are going to staple the towels to the patient. And they're going to staple them just like as far on the sides as possible and as high up, like near the neck as possible. And to keep those towels from moving or shifting, they will literally staple those to the skin. So remember, those have to be removed when you come back. Oh, hi.
Okay, again, because, I picked favorites. This is my favorite. I love it.
Hi, how are you?
They just they're on their motorcycle. And so what'd you guys do? You guys rode originally from home, which is in Colorado Springs.
We got 2,000 miles on right now.
Oof. You didn't tilt when you got closer to Arizona?
Yeah, it was bad yesterday, 119 going from San Diego to Yuma.
Oh, yeah, Yuma. 368 days of sunshine in Yuma. Yeah.
Get out of your hair.
I love you. Go
Good to meet you. Okay, good job. Any questions about the breast prep or anything?
I have a question. So it said there that we have to be careful not to press too hard, like if it's a tumor. Yeah. So just by doing the scrubbing, you could disturb that tumor enough that it could reseed?
Yep.
Well, that's terrifying.
Break off parts of it and it could metastasize, essentially, I guess. I don't know what the probability of that is. It's possible, but I'm not sure how probable, but that is something that it's a thing, and you'll see that you'll see that demonstrated in surgery, you know, when you're doing a mastectomy or something like that. Like the surgeon's going to remind the circulator, like, you know, do a very gentle prep because we don't want to disrupt, you know, the tumor or whatever. Yeah. It's pretty crazy. Good question. Okay, let's talk about the shoulder.
So the shoulder is it's straightforward, pretty basic. So it starts from the neck down to your shoulder, the upper arm to the scapula. And again, just sterile gloves, towels, prep solution and containers, applicator sticks, and sponges. Most of the time the hand is excluded from the prep just because the fingernails are considered contaminated, and if we can avoid going down there, then we're going to. And unless the patient has any allergies, or if it's a little baby, then any prep can be used.
And then a quick overview, the square area, or you square the area with sterile towels, make sure area is clean, shaved if needed. Markings where the incision will be made, so you're identifying your landmarks, and then identify portal placement, and then they will begin the operation.
Okay. That's good. Is that the only slide that you guys have, or is there another one?
That's the only one.
Okay. Good. No, that's perfect. I was just gonna speak to this if you guys were, if this was all the content that you had. So, what was I gonna say? They also prep the axilla with this as well. It's kind of, they wait and prep the axilla last and pretty much down to the wrist when they're doing like a shoulder scope or something like that. And the patient is going to be in that beach chair, that semi-Fowler's kind of position. So it's going to include the front of the shoulder, but it's also going to include behind the shoulder as well, like probably to include like to the will that be medial aspect of the scapula. Okay, so it's also going to include the back as well.
Yeah, like the picture in the right, it goes on both sides. It's pretty much the same on either side.
On both sides.
Would they go that low on the back normally?
No, especially if they're in the beach chair, like probably only this much of that shoulder is even going to be, or the back is even going to be accessible sitting in the beach chair. If the patient is lateral, which sometimes if they're doing like a labral repair, repair of the labrum, then they'll put the patient in a lateral position. And so the prep might be extended a little bit more on the back, but still it's a limit to how much back is going to be exposed if you're in that semi-sitting position. Yep. Good questions.
Oh, thank you.
Yep. Other questions or comments about the shoulder prep? There's a significant amount of draping that goes into draping a shoulder, which we'll go over at some point. All right, let's dig into the extremity.
Okay, so the leg prep is similar to the arm. The prep extends from the ankle to the groin, and then the limb needs to be elevated, either in a leg holder, or I guess if you have enough people, someone could hold it, right? Okay,
Mm-hmm.
and then for supplies needed, a nail cleaner if you're prepping the foot, foam scrub, sponges, impervious sheets, sterile gloves, and then the leg holder. And then the technique, first you place a sterile towel between the groin and the fold of the upper leg. Like I said, the leg must be elevated. And then place the impervious sheet over the OR table and the non-operative leg of the patient. Since the leg is elevated, the prep must begin at the highest level and then you work down to the lowest. If the foot is included in the prep or in the scrub, you would do pretty much the same as you would the hands. And then if it's excluded from the prep, you perform a wide skin prep around the operative site. And some indications and contradictions that we came up with is allergies. So if they have an allergy to latex, shellfish, or iodine. And then it's difficult to remove or reduce the microorganisms around the nails of the foot. That's also another one.
Gotcha.
Yeah.
And then for the arm and hand, it's going to be very similar to the foot and leg. And again, it's totally dependent on the incision site. So whether you're prepping the whole arm or just one part of the arm or the hand. And so same supplies needed, which is the nail cleaner, a foam scrub, sponges, and pervious sheets, sterile gloves, prep solution kit. And then for the hand, you always begin at the fingernails because they are typically the grodiodiest. And then you have to cleanse subungual, begin at the incision site, move in circular motion outward. The upper boundary is a few inches above the elbow for a hand surgery, or if a beer block anesthesia is used, you go up the arm to the level of the tourniquet. And sometimes the arm prep may include the shoulder, depending again on the location of the incision. The indications and contraindications, it's hard to remove the microorganisms around the fingernails and in between the webs of the fingers. And then obviously any particular allergies, particularly to the iodine.
Yes, something else we need when we do hand or arm surgery is a hand or arm table, they call it. And so that's just an extra device. There's a couple different ones. There's ones that kind of they kind of lock on to the side rail like the arm board does, or there's other ones we would call them like the ironing board, and it kind of has a pad on the end that's long enough and wide enough to support the arm, but it has like this metal part at the top, and you just slide it under the pad of the OR table, and then it has a little kickstand that comes out and kind of supports the end of it. So either way, if you're working on a hand or an arm and it's not a shoulder, then you're typically going to have it out to the side, and you need a bigger space to work than just that traditional arm board. So they have a special arm table for that. That's my only other thought. Good job.
The next slide is just a bunch of pictures.
Okay, and you had a video too, right?
Yes, I sent that to you privately.
Yep. I have it ready, so I'll show that after you speak about this.
Okay, so obviously just this one here shows, the leg being elevated, and it's not in a foot cradle or anything like that. It looks like the circulator, whomever, is just holding it. She must be strong, because I don't know about you guys, but my leg's heavy. I mean, you go, girl. But, it's just different methods, I think, of doing the prep. So it just kind of gives you an idea. Obviously, we've got the one that's similar to in the book, where you always start at the incision site and move in a circular motion outward. And then the next is the Grodiodi video. Sorry.
Okay, we're going to go for that. Let me stop sharing this and go to the other one. Let's see, where is it? No, I thought I pulled it up. Okay. I might just have to escape from this. Exit. Escape. Okay, can you see the video? Am I still sharing? Okay, here we go.
Toss that one down. This is down, this one just inside. Just inside the wound. Stick it in the wound. Stick it in the wound. There we go.
Stick it in the wound.
Got it? That's the town. Just take the line around. And you do all the foot first. And then you touch the wound wise.
Don't forget around the heel. Down there.
Around the heel.
I wanted to point for the camera. I'm pointing for the camera. Ignore it.
Okay, now touch the inside of the wound, then we're done. Okay.
No, you gotta do it right here.
Yeah, we're
Bossy, hey? Okay. That's a good foot video. Good job. Good pictures as well. You can see this is a good view of the pneumatic tourniquet. And you can see this has a tourniquet too, but a lot of times, most times what they'll do is they have like this little clear drape that has like a sticky adhesive end on it. It's called a 10-10 drape. And that will get pulled with the supplies for your case. And when they put the tourniquet on, this is what it looks like without the 10-10. Then they will put the 10-10 with the adhesive sticky part around here and the rest of the tail going back this way. And that's gonna help keep the tourniquet clean, right? And from getting this prep solution on it, getting it wet. It also helps to create that barrier between the tourniquet and what we're eventually going to drape the patient with. So you'll see that pretty much frequently. Okay, good job. Questions about extremity drape or extremity prep? I left my chat box somewhere. Okay, here we are. Okay. Good job. Abdomen.
Okay, so for the region prepped, it extends from the nipple line to mid-thigh on both sides of the body, so both left and right side. And then the supplies, so you do need 2 separate prep kits. One is for the perineal area because you have to go down to mid-thigh on both sides. So you do need a separate prep kit for that depending on what type of prep solution you use because that is a sensitive area. And then, so you need the prep solution and or scrub, sponges, sterile towels, drapes, basins, and sterile gloves.
Good.
For the technique, so you would square the abdomen with sterile towels. You would begin prep at the umbilicus and cleanse to remove loose dead skin. You would start at the incision site and move to the periphery. And then if soap solution is used, you would blot dry and apply antiseptic paint. And you would wait for that to dry before putting on any type of drape. For indications and contraindications, it says open wounds would not be prepped with alcohol-based agents, so such as the povidone iodine solution. And then if we were doing the abdominal vaginal procedure, it would require 2 separate skin preps, and then always check if the patient has any type of allergies.
Awesome. Good job. Questions about abdomen? Are you starting to see some similarities in these?
Actually, I did have a question that just occurred to me right now. If it's a larger person with a lot of excess tissue in the abdomen area, those areas are considered probably pretty contaminated, correct? Like, would they be prepped like the umbilicus would? It just kind of occurred to me right now. I'm not sure.
So yeah, that's a great question. I'm trying to think if I've ever seen them prep differently in that situation. I would say the only thing that I could think of is if there's some sort of wound, like, you know, if if there's a pannus and, you know, if the individual isn't like drying well in there, or there's some sort of infection going on or open wound, then definitely would want to prep that like separately or with new sponges or whatever the case may be. I haven't ever seen them use 2 different preps, I don't think, but that would be, in my mind, the reason why if they were going to use 2 preps or prep it differently, is if there were like open wounds or infected wounds or something like that.
Okay, thank you.
Yeah, good question, of course. Any other questions? Okay, good job. Thank you for putting that together for us. Let's talk about the flank and the back.
All right, skin prep starts at the incision site and moves outward, and the prep site extends from the neck to the sacrum. And then supplies is sterile gloves, prep solution per surgeon's order, towels, prep sponges, sponge forceps, sterile water or saline, several small basins, a razor. And then technique, square off prep site with the sterile towels, apply antiseptic and circular motion starting at the incision site and working outward. Continue this pattern twice. And then contraindications, avoid using alcohol-based prep on open wounds and follow all allergy alerts. And then our pictures.
Good. Yep. Looks like they're using ChloraPrep there. Another thing that I thought of you might see and might need for this type of prep is, remember how I mentioned the 10-10 for the extremity to go around the tourniquet? Sometimes they will take a 10-10 and they will put it just above the buttocks here. And so the sticky end will go across the buttocks here, and then the rest of it is extending down this way, just to kind of isolate this area from the area where we're going to be working. I have seen that in some instances. Good job. Questions about this one? Pretty much similar to the abdomen, huh? Pretty much in theory. Good. And then we're going to prep, they're going to prep probably as far lateral as possible, or as down to the table, we say. Good job. Thank you. All right. Who's up next with the vaginal prep?
Hey guys, we had vagina, me and Alyssa. And the 2 stages are stage 1, pelvis, labia, perineum, and thighs. Then stage 2 is vagina.
Okay.
We're going to the next one.
So they got the popsicle stick stuck in there.
Yes, I try to look for.
That was a good one.
Sufficient photo, because some of them were kind of a little whoa.
Yeah.
And then the next one, vagina, supplies needed. Prep solution, Provion iodine, sponges, sponge forceps, and previous drapes, perineal barrier drapes, and prep towels. And then there's a photo for an examples.
Very good. Oh, the mannequin.
Yes. And an overview, Alyssa will be talking next.
Okay.
Okay, so first you would start at the pubis using back and forth strokes up to the iliac crest. Next comes the inner thighs and the labia majora using downward strokes, like when we did the catheterization, going downward and discarding used sponges as you go. Then lastly, you would prep the vagina using downward strokes and blot the excess fluid from the vagina and surrounding area to prevent the chemical burn.
Yep, sometimes I'll see them when they start the prep, they will take one of the sponges on a stick and they'll put it in the paint solution and they will stick it in the vagina, and they'll do all the scrubbing bubble prep 3 times, and then they're gonna remove that stick, and then they're just gonna go in the vagina 2 more times and be done. So you might see it that way as well.
And some indications and contraindications are to not use alcohol, use solutions that are approved for mucous membranes like the eye and the ear, I believe. Using, what is it? Yes, the povidone iodine. And to not let the solution pool between the buttocks and the table.
Mm-hmm. Yep, they'll typically stick a towel like underneath the buttocks, you know, before they start. Or I think I might have mentioned before, sometimes they'll put like they'll take a plastic trash bag and they'll stick it under the buttocks. And then as they prep, like their trash is just like right there. They'll prep and then into the trash, prep and into the trash, which is probably what we'll practice in the classroom. Good. I think PCMX is another one that's okay for mucous membranes. Excellent. Good job. Questions about the vaginal prep? Thank you, ladies. Oh, you got another video? Okay, Rainey found a video for vaginal prep. You guys want to watch that? Okay, hold on. I'm gonna figure out how to make this work. Escape. Is this it?
Yeah, I came across it when I was trying to like find videos for catheter insertion and whatnot when we were going through that. And I came across this and it was kind of mind blowing, I have to tell you.
Okay, let's do it.
Might have to fast forward through some of it, but.
Let's see.
So this is
Where are we at?
iodine-based antiseptic, top of the vagina. I'm going to leave it there. Now I'm going to start prepping the outside of her vagina. And what I'm going to do, I believe in good preps. This is standard betadine, right? If you prep them, you should prep them correctly. And I like to prep back to mid-thigh. Okay, then I do it again with another one, a cleaner one, okay?
Cleaner one.
Go clean to dirty. So now what I'm going to do, remember this has been in here since before we started. So now I'm going to work this way all around the top of the vagina. You see that? Good prep. Because there's a lot of bacteria in there. The vagina is not a clean organ. So then I'm going to come out and do the same thing. And then I'm going to put another one and do the same thing. This is a Foley catheter, urinary catheter.
Okay. That's all we need to see, huh? His badge is in the way. He needs a pull badge.
So I saw that he was going over some areas over again. Is he supposed to?
Girl, okay?
Yeah, that's the old school guy for you. And I don't know that I've ever seen any prep where they've spent that much time like swabbing the cervix internally, but yeah. Okay. Thank you for that video. That was a good one. This thing just gotta go away. Okay. Oh. Hold on. This Zoom needs to think of a better thing for that. Okay. Present. Okay. Awesome. Thank you. That is always helpful. All right.
Penis and scrotum. Skin prep will include the penis, scrotum, upper legs, and inguinal areas. Minor procedures indicate excluding the peripheral areas, and patient will be prepped in a supine position, and obviously this patient has their legs frog-legged.
Could also be in lithotomy as well, just a side note.
Okay. Supplies needed. You'll want non-alcohol prep solution, sterile saline and or water. You want some cotton balls, some sponge forceps, and sponges that are impregnated with the prep solution or plain sponges.
Yes.
And obviously towels and drapes.
Yes.
The technique used, you will place the sterile towels on each side of the hips and under scrotum. That way you can catch any excess runoff. If the penis is uncircumcised, you'll want to retract the foreskin before you start. Prep the external urethral meatus and extend to circumference of penis and base. Repeat steps until the penis is entirely clean. Then you're going to move on to the scrotum with detail getting into all the folds. Then you're going to do the thighs and the inguinal area, prep each side of the groin moving outward. And alcohol-based solutions are contraindicated, as well as saying no to any allergies and surgeon's preferences.
Very good. Yeah, if they're gonna do like something in the inguinal region, like a inguinal hernia repair or something like that, it's going to include a penis and scrotum prep. And one of the things that the surge tech might have to do is once the nurse is complete with the prep, they're gonna hold up the scrotum and the penis, and then you're going to place a towel like on the thighs, and then the penis and scrotum will be laid on top of that, and then we'll drape over that. But just in case, like sometimes the surgeon will need to like tug on the scrotum intraoperatively, and so that gets prepped out just in case. Oh, okay, that's it. So any questions? Thank you so much. Any questions about that penis and scrotum prep? Okay, then let's wrap it up then with our last one.
The perianal prep includes the anal region. You prep the inguinal area and thighs, and for surgery of the colon and rectal surgery, to clean that lower region, you need tape to spread open that area. Okay, next slide.
So the overview of the technique, the patient's gown and cover sheet is removed, and it kind of exposes that lower area, and there may also be stirrups included or boots just to have that exposure. And then again, that tape kind of moves the butt cheeks apart to ensure that they're able to get in there. And they want to be able to, there's a couple of different ways that we were informed of. They can either, they don't start with the anus area, but they may start around it and move 12 inches out. They can also start in the thigh area and the surrounding area and move inward. And then when that anus is prepped, that's done last, unless it is instructed that it's to be excluded. So it's very similar to the vaginal prep as well. The patient can also be placed in the lithotomy position for abdominal perineal resections. So this would require a separate prep.
Yep, or we might be doing this in Kraske as well.
Okay.
I was gonna ask, I was like, are they laying like supine or are they prone in the jackknife position? But they can happen in both positions.
Mm-hmm.
Okay. Yep, definitely. And so I've had some surgeons say, the chief of surgery that I worked with for a long time, anytime she did anything in the perianal area, she wanted them prone in the Kraske position. And then she didn't want hardly any prep at all. Like, she's like, we're working in the rectum, it's not really necessary. And if they're using that tape and they put there's some like adhesive spray that they use. So like the nurse will spray the adhesive on the buttocks on each side, and then the tape will be placed there, and then that's used for the retraction. But the more you prep in that area and the wetter the tape gets, tape's not going to stick. So it's very minimal prep. That's been my experience. And some surgeons are just like, yeah, don't worry about it. One of the general surgeons I used to work with, Dr. Leibowitz, he would say, when you're doing a rectal case, you wash afterwards and not before. So anyways, it was kind of his little joke, but we'll get the point. Okay, do you have another slide?
Yes, 2 more. Is that you or me? Okay, for contradictions, you have to be prepared to clean both areas, or like Tammy said, like you either clean the rectal area or you don't. And you could use a 2-stage method, and only the providone iodine solutions are used, or the PCMX, because it's the mucous membrane. Yeah, no alcohol is used for that area. Okay, next slide. For the supplies, it includes the sterile gloves, tape, the providone iodine PCMX solution, a sponge on forceps, a perineal drape, fluid collection pouch, and impervious drape. Yeah, and that's it.
Awesome. Very good. Questions about this? Okay. Awesome.
Yeah, do they leave the tape there during surgery? Like you put the tape there for cleaning and then you just leave it there so nothing like falls back together, right? That makes sense.
Yep, we just leave it there. And the tape is in your sterile field. And it is not sterile. But it's not a sterile area. So yeah. Yep, you got it. So there's just there's one more little piece I had on my presentation. The book talks briefly about additional, I just labeled them additional considerations for trauma and debridement, or as Dr. Erickson would say, debridement, and then autografts and cardiovascular surgery. So in regards to trauma and debridement, I liked this picture look. It's like the entire body is prepped. I have no idea what they're doing, but I was like, oh my gosh, I don't know if that face is prepped, but pretty much the entire body is prepped. And if they're doing some sort of abdominal aortic aneurysm, and then they're going to do like that bifurcated upside down Y graft, they will prep from xiphoid or nipples all the way to the feet. And then this has to be draped out. So a down sheet, a groin towel, both legs and the abdomen are going to be draped out for that. So some additional considerations for trauma or debridement is that, there could be devitalized tissue that the surgeon's going to want to remove. And a good example of that was the video that Graney's group had about prepping that foot with the open wound, right? So you want to kind of prep all the way around that and then prep that open wound last. Or if you are going to prep the open wound, discard that sponge and not spread the rest of it, all around everywhere else. For an autograft, I have mentioned before, for the donor site, which is where you're taking the graft, you want to use a clear prep solution. Okay, so something like Hibiclens or PCMX. This provides the surgeon with a clearer view as they take the graft. And then for CV surgery, again, could require a full body prep depending on where they're working, what they're doing, if they're doing some sort of bypass, that sort of thing. So just some additional considerations. And in this case right here, this is so hard to keep these patients warm, really hard. Their entire body is going to be exposed to 65-degree environment for who knows how long. It could be hours and hours. And so that painting them with cold prep solution does not help the situation. So there's a good chance that patients will leave surgery hypothermic because of their exposure to the environment. Okay. And that pretty much wraps up prepping. Okay. Any additional questions about that stuff? Violent reactions?
I do have questions about like trauma centers when somebody's rushed in and you have to do a really quick prep. What does that look like?
Dump it out of the bottle onto the patient and go.
Okay.
Yeah. One situation that sticks out in my mind was an emergency C-section. And the mama had no prenatal care. She was 26 or 27 weeks along. She came in, she had decreased fetal heart tones. And so we did an emergency C-section. And I was not in too much of a hurry because there was a tendency when they called for an emergency C-section, it was 15 or 20 minutes before the patient was back to the OR. So I was sauntering around gathering my stuff and hadn't even opened my back table pack yet. And here comes the patient. And I'm like, oh my gosh, this is really an emergency. And so I hurried up and opened my stuff. And I just remember probably as I was throwing some waterless scrub on my hands just so that I could jump into my gown and gloves, I glanced over. Patient was already on the table, and our circulating nurse, Ron, had just tore open a kit, like didn't even know sterile technique whatsoever, tore it open, got the paint out, took the lid off, and just poured it, just doused the patient with it. By then the surgeon was there. I threw his gown and gloves on. I gave him a drape. We threw the drape down. We got over, we made the incision right away. It was a poor outcome nonetheless. But that's the one time that sticks out in my mind of just, you know, at that point, it's life or death. Are they going to do a prep or not? Does it really matter? Let's do what we got to do. Let's save our patient. We'll worry about infection later, kind of thing. Let me see your comment, Ian, too. Yep, for sure. Yep. You know, it'll all come full circle. Talk about it, we look at it, we kind of gain an understanding of it, look at the theory behind it, and then we'll practice it. And hopefully things will come full circle with that. Yeah, for sure. Good, I'm glad it was a good review though for you. Any other questions or comments? There is, so we're gonna wrap up here. It's about 11 o'clock. Your activity for today is for Blackboard is going to be a self-reflection. So the document that you are going to use is attached in the Blackboard, to the Blackboard activity for today. and it's called Student Self-Reflection. And I just had pulled it up on my other computer so I could just speak to it, but the attachment is there for you. So you just open that up, and then you can just type the content right onto the document. So it's going to ask you to identify your strengths during this course, some areas of opportunity for improvement, your action plan for improving, right? Because this is important to always reflect on how we're doing in our hands-on skills. So, you know, if that can be your focus, and, you know, we're just kind of scratching the surface of our hands-on skills, but it is extremely important for us to pause and reflect. And so that's what this is about. And if you want it to be about the content as well, it definitely can be about that as well. But some goals for improving. And then the number 4 question is ways that you think your instructor can help you improve, which is good feedback for me. And then there's a part where instructor could leave comments. You know, you don't have to worry about signing or dating or anything other than that. But I would like to see some thoughtful reflection, not just like, you know, a one sentence or one word. Like, let's kind of think about this and put some thought into how you feel like you're doing, what you feel like you're grasping, you know, easily, things that seem a little bit more difficult. We'll definitely start doing these practices as a part of every class in some form or another, whether it's an audit of a competency or whatever the case may be. But reflection is definitely a part of our growth. And then, you know, on the heels of that, sharing best practices with each other, right? I think is also a good component. So we'll also start to do that a little bit more as well. Okay, questions about what you need to do for your activity?
Are we also posting the link for the LVL 7?
Yes, for the LVL, you will post the presentation link. Okay. Any other questions? Okay. All right. Well, I look forward to reading your reflections. Have a good weekend. Be safe. Get some rest. And I will see you all Monday. Okay. All right. Bye. Thank you. Bye.